I will now welcome Cindy Yip, Director of Data Knowledge Management and Heart Program at Heart and Stroke. Thank you very much, Kirsten, for the introduction, and welcome everyone. I'm very excited to introduce our webinar panel. Today with us, we have Valérie Hay. She's a people with lived experience and is going to share with us her experience living with congenital heart disease. Also very excited to have with us is Dr. Lorna, Swan, and as well as Shereli, Soldevilla. Both of them were going to bring us their clinical perspective and provide some tips on how we need to work with a congenital heart disease patient, as well as some of the practical tips on what to watch out. And as mentioned, I am the moderator of this session, and we will be taking in questions at the end of this session. So please remember, as you are listening to us, enter your question in the platform, and we will be addressing them. Our learning objective today, I really hope that all of you are going to be able to learn a little bit more and then explain and be able to join us to examine some of the woman-specific care and needs for those who are living with congenital heart disease. Before I start, I just wanted to celebrate with everyone that, as many of you know, February is Heart Month, and we are very, very fortunate to be able to share this moment with you and all of the advocates out there. There has been lots of momentum being built and funding that is available to support the research in heart disease and stroke and vascular cognitive impairment to better understand women's needs and some of the existing gaps. In this year, Heart and Stroke 2020 Heart Month Spotlight, we have dived into 3 promising stories with notable research advancements that may change the life of women and their experience with heart disease and stroke. What is shown here is one of the examples which highlights the life of an individual, Jennifer, who is a heart and stroke staff who lives with congenital heart disease, and they provide an example of how she was initially born with a malfunctioning aortic valve, and later on she has to go through a surgery at the early age of 29 in order to save her life, which have left her exhausted and in many months of pain. And that journey she has very generously highlighted and shared with us in this spotlight. And along with that is some of the work done by Dr. Clavel in University of Laval, funded by Heart and Stroke, and she's looking into a promising drug that can potentially target fibrosis, a major contributor of aortic valve disease. And if successful, she, especially with her work, is going to help us understand what is so unique about women and congenital heart disease like the one Jennifer has experienced, and potentially avoid or postpone having additional surgery by replacing surgery with a therapeutic drug-based approach to target to target this problem. In addition to Heart Month, which a lot of us is working really hard on to raise awareness of the women's specific needs and care needed when they are living with heart disease, is we also, for the first time, working with 5 patient-led collaborators to help raise awareness of congenital heart defects or disease. And we are this week particularly having a lot of activity on the social media channels and reach out to boost awareness and also share some patient resource that you can use yourself or you can use with your patients in your practice. So I hope together with you, the audience here and our panel here, we will be able to change the life journey and help smooth out the transition for those living with congenital heart disease from pediatric to adulthood. A couple of key facts on women-specific aspect of congenital heart disease. Congenital heart disease ranges about 50 to 150 per 10,000 births, and it is one of the major common congenital abnormality among newborns. And many of you may not be aware that women with congenital heart disease are actually 27% more likely to happen than males. And they're more likely to have functional limitations and other challenges. Women with congenital heart disease also have 33% higher risk of pulmonary hypertension than men, which often contribute to the additional functional limitations. And furthermore, because of women's specific life journey, many of us may want to or are planning or have had kids, right? So many of us may opt for certain treatments options that may actually require them to go through additional surgeries or have to face additional risks. For example, one may opt for the less durable replacement valve just so that they can have the chance to have children, and in that case, they may actually have to replace their valve many more times in life instead. And not to mention, current Canadian, most recent Canadian data, we have found that women are 25% more likely than men to die after aortic valve surgery. So you can see the added complexity of not only picking a valve that potentially is less durable, but also having to have to go through more surgery and increased risk of dying from a surgery. So with that, I think, no further ado, let's turn it over and listen to our individual with lived experience. I'm going to turn this over to Valerie to share her lived experience with us. Thank you for joining us, Valerie.
Hi, everybody. No, that's okay. So I hope that everybody can hear me. My name is Valérie Hay, and I was born with a tricuspid atresia, and I went through a Fontan and got a pacemaker, and I'm followed at the Montreal Heart Institute in Montreal. So what is tricuspid atresia? Okay, so just for you that don't know, this is basically my heart when I was born, and I got a classic Fontan that re-put the balance, and basically I have only the left ventricle that the left ventricle that push all the blood to the organs, and for now anyway, it works really well. So through this, I was born in Montreal, but I lived. Wait a sec. How come it doesn't work? So I want to change. Thank you. The slide. So I grew up in a small town, and for sure that because congenital heart disease is not that much common, I was basically the only one that was different at that time. From what I've seen in the statistics, congenital heart disease patients are 10 times less in number than diabetics. So it's just to give you an order of perspective. So I was really, really highly lucky to have parents that were really involved and that did fight for me and fight to get the services. So I was able to go to school, do my up to high school in Temiskaming. And for sure, like probably in many patients, the goal is to live a normal life. That's what the family wants, that's what the kid wants, and that's what the parents want. So my goal was always to live a full life and a normal life. So after the Fontan, that happened at around 11 years old, I went through high school, and after high school I had to move. So I've done a first transition to so is it no, I need to get the slide one more. So thank you. So I left home basically and did a first transition to Montreal, and that was about at 16 to go in and pursue CEGEP. And basically, I was still on the kid side, and but was living by myself and learned to take care of myself, even though I was in basically the kid system. So, and I went through a second transition when I went from kid hospital in Saint Justine to the Montreal Heart Institute. So I was lucky enough to be involved in a project that about transition, and I've learned a lot. That basically I've learned that kids and patients basically need to be educated at that point, because all their needs and all their care were taken care of by their parents. And parents need to learn also to have confidence in their kids and children that they will do the right thing and they will take care of themselves. Um, Kids need to, well, kids, young adults actually at that point, um, we need to learn to take care of ourselves and to um, get the services and what we need basically. It's a challenge, I have to admit, because the two systems are highly different. You go from a more maternal system where everything is under the same roof to a more, I would say exploded, but really scarce system where you need to go and pick your services and you can choose. So even though I had to fight for the services, I went and did an undergrad and a master, and I was lucky enough to find a job. So I worked for many years in the lab and move also. And so after that, well, right now I'm in a second career. So just to let you know that even though I have congenital heart disease, I was able to progress in life and live a full life. So as a woman, for sure that it can be a challenge, and we need to take, unfortunately, specific decisions that are really unique to us. And one of them is the pregnancy. So I was talked about pregnancy about at 20 when I went to the adult side, but I feel that it should be talked way before, because then you need to take decision about not having kids, or you can decide to have kids anyway. Some congenital heart disease allow, well, not allow it, but are less demanding, so your heart can support it. So it needs to be talked about, and those decisions are in the same way as career um, picking, and we need to adapt to what is we're able to do. So I put there as basically a colorblind person that I may not be able to be an electrician. So that's said, um, women have specific needs like mammography and osteoporosis, and I didn't put some of the cancer that we have. So they need to be taken care of. And all of this put a stress and heavier stress on us. And most of us are head of our household. I'm head of the household. I'm by myself. So I need to take decisions. I need to make sure I have a job to be able to pay for everything. I need to find a job where I'm able to leave and get the treatment I need. And so that means that if an employer is willing to take me and is willing to work with me, we need to have a good collaboration to be able to, for me to get the treatment and be in an environment that is suitable for me. with my limits. So it's for sure that congenital heart disease women are not, we need to manage the stress, and we need to manage our expectation also, because I think women have high expectation of themselves. So it's, it needs to be managed also. So for me, in my view anyway, the relationship with the cardiologist is key. It needs to be open, and the cardiologist have a lot of information. He needs to pass that information to the patient without any secret, because we need to take the decisions, and a maximum of information teaching us what are the symptoms will help with those decisions. And it's basically a relationship that we build over time. I cannot stress enough that even though I have congenital heart disease, I need other help, other specialists. And those specialty are sometimes, they don't know what to do a little bit with us, so they need to be able to seek that information. And I think that cardiologists that has that knowledge are willing to give those information to the other specialists. And because the pediatric cardiology is evolving and getting better at saving all those kids, we're getting older, and so we need the resources. We need different resources. We need general practitioner, we need dentists, we need dermatologists, whatever specialty we need. And for now, they're not all there, and a lot of doctors are a little bit unwilling to take care of us or unsure of. So that being said, I think that the message needs to be that the relationship between any healthcare provider and a person with congenital heart disease is key. The communication, the relationship can be built, and women, especially women, I feel, are really intuitive. So you need to listen to them. You need to be, it needs to be a partnership basically. And it's for sure that treating congenital heart disease patient is a challenge, but at the same time, I want to believe that it's really rewarding. And for me, in my life, it's always been a balance between being normal and having limit because of my defect. So it's a balance that is really needs to happen even with the relationship between the healthcare provider and the person with congenital heart disease. So I think that patients are getting older and they're going to need the services, and we're not going anywhere. So hopefully that all the doctors around that are listening will accept to treat congenital heart disease women and congenital heart disease patient, for us to be able to live to our 100% basically. I had a last slide where basically I try to live my life at 100% all the time. So hopefully that you guys are convinced that it's worth it and it's really rewarding, and that you're gonna, I'm sure that the healthcare system will benefit and will be able to provide us all the care that we need. For now anyway, I was always been really well treated, so that's why I can have the chance to speak to you. So one of the cardiologists that is willing to talk to us is Dr. Swan, also, that's going to go after me, I believe. So think that she's going to be really intuitive, and it's going to be really interesting. So I'm passing the microphone to Dr. Swan.
I'm just going to pick up on a couple of points that Valérie made, and thank you for that, and thank you for that very positive message. If I could get control of my slides. Yeah. So I think the first thing to say that with many things in life, there isn't a fair playing field in terms of many aspects of medicine, and say this swings in both directions. So you've heard already that men are more likely to have certain complications and women other complications. So men, for example, with congenital heart disease are more likely to have aortic complications, things like endocarditis and sudden death. Women, as you've heard already, are more prone to develop pulmonary hypertension as a complication of their congenital heart disease. They're more likely to need a pacemaker. But by far the biggest issue that drives really these conversations, the whole issue of reproductive health. And that might be everything from pregnancy through to menopause. And I'm really just going to elaborate on a couple of those points. So I'm going to do that by just elaborating on a couple of cases. So the first case is a patient with an AV septal defect, and I don't know whether you can see that little drawing there, but remember that's essentially a hole in the middle of the heart, often with an atrial and ventricular component, and often abnormal AV valves. So these are all true cases. So an 18-year-old patient. So she had very successful repair of her AV septal defect in childhood. And from her point of view, completely normal, a very normal life, fit and active. However, we know that she has some significant AV valve regurgitation. And say this again is not an uncommon scenario. Now, if she was a male, her pattern of care would be relatively straightforward. So we would wait until we saw the left ventricle dilate, we would wait until potentially there were some symptoms, and then our 18-year-old male would in the future go on to have probably a single operation with replacement of the left AV valve with a metal valve. And likely that would be his only other operation. But as you'll see in a second, if your male patient is actually a female, this whole disease trajectory is much more complex. One of the reasons it's complex is we know there are particular types of congenital heart disease that are very tricky if you've got congenital heart disease and pregnancy. And one is having a metal valve. And this is just showing some data from the UK. And they looked at 58 women with metal valves. And you can see, shockingly, 5 of these women died during their pregnancy. And that was related to mainly issues of valve thrombosis, either the valve thrombosing or thrombosing and embolizing and causing a stroke. In addition to that, 40% of them had a severe or serious morbidity. And again, that's either related to clotting with stroke and thrombosed valves or to bleeding. And about a third of them had a significant bleed during the pregnancy or peri-delivery. It wasn't only maternal outcomes that were challenging, it was also fetal outcome. So of the ongoing pregnancies, 43% of them had a poor fetal outcome. And we're collecting more and more of this data, as Valérie said, as our patients are getting older. So that brings us back to our 18-year-old, and this patient's just transitioning from pediatric to adult care. So what options does our patient have? So we could treat her like a male, which is fine, and replace her AV valve when she needs it. But that would mean potentially any pregnancy she had after that surgery would have a high risk, and potentially mortality even up as high as 10%. There are a couple of other surgical options, as we've alluded to already, and that would be to do something surgical that was not going to last as long. That might be trying to re-repair the valve or use a tissue valve with the hope and not the guarantee, but with the hope that that would reduce the pregnancy risk. However, that obligates the woman to having yet another operation further on in life, so having her third sternotomy and cardiac surgery. The other options, as we've talked about already, are to decide not to have children, and obviously that comes with a huge amount of difficulty and of psychological issues, or potentially even more frightening to an 18-year-old, the advice that if she is going to have children, she should have her children soon. And I say to present that to an 18-year-old who's just transitioning from paediatric care, if that's the first time they've ever heard that message, as you can imagine, is very difficult. And it leaves the patients with multiple questions. And I say often the patient doesn't look quite as serene and sort of chilled as this lady here, but issues about having to deal with complications, not even knowing at that stage whether you have a fertility issue, and questions of, well, how can we predict the future? How much risk is too much risk? And what if I change my mind? Do any of us at 18 know exactly what we want when we're 28 or 38? So these are difficult, complex discussions. And I say one of the things I'd really like to hear from the audience in terms of questions is, when should we start these discussions? As Valérie said, after you transition to adult care might not be early enough for patients to begin to work through some of these issues. Before I go any further, I'd really like to just remind us all that the vast majority of women with congenital heart disease have successful pregnancies. So almost all of them will be able, with good medical care, to have a successful pregnancy outcome and go on to fulfill the desires that they have to have a family. But I am going to focus on one or two of those issues that are challenging. So another challenging group, and I say Valérie has mentioned this is one of the types of heart conditions she has, is to think about a patient with a Fontan. So here's a case of a 26-year-old with a Fontan. Remember, a Fontan is that circulation where you're unable to sustain two ventricles, and we use some form of plumbing to connect the systemic veins back into the pulmonary circulation. Many of our Fontan patients are anticoagulated, and that brings issues for women in itself. So this patient already had menorrhagia with very heavy periods, had also had another complication that I had seen quite frequently in women who were anticoagulated, and that's an ovarian cyst that ruptured and caused retroperitoneal bleeding. And the patient comes at 26 saying that she would like to start a family. If we look at the Fontan patient population and the information we have about pregnancy, you might think this is a very rare topic. But actually, and this is data from New Zealand and Australia, you can see the number of Fontans is exponentially increasing. So over the last 20 years, a doubling in the number. Over the last 30 years, the number is increasing by a factor of ×5. So these are conversations that I have as an ACHD person relatively frequently. And when we talk to a patient about starting a family, we talk about the cardiac risk, but that's not the only component we talk about. We have to talk about things like fertility, other organ systems, risk of miscarriage, risk of the baby not growing properly. So this is only, the cardiac risk is only one part of a much more complex jigsaw. If we look at the Fontan patients in particular, and here's some data from the UK, just shown pictorially. So if these are 50 women with a Fontan who are actively wanting to become pregnant, the bad news is that 40% of them will never conceive. And this is quite unique to our Fontan patients, that there seems to be some link with infertility that we don't quite understand yet. The patients in pink, which are about another 20%, will only ever have miscarriages and will not go on to a live birth. What does that mean? Well, sadly, it means, at least at the moment, of the Fontan patients that we have, my slides are going mad, let me go back. Of the Fontan patients that we have, that less than half will go successfully on to have a live birth. And if they do have a live birth, they have additional challenges. So small babies, so growth restriction, early delivery, so preterm delivery, and multiple peri-delivery complications, including things like neonatal death. So if we think about this group of patients, and this is one of our more complex group of patients, there are definitely multiple hurdles for women if they're thinking about having a pregnancy. The first is fertility, the second, miscarriage, the third is some of the bleeding complications, again related to anticoagulation, and some of the fetal risks. And that's in addition to the general health issues that a Fontan patient might face, which involve in the future issues with other organs being involved. For all our congenital heart disease patients, discussions about longevity and quality of life. And one of the big questions is whether having a pregnancy impacts on your long-term outcome. And again, there's really very limited data about that. We definitely know that having a pregnancy may reduce your transplant options. And so we can discuss that at the end if we have any time. And the final case that I would like to mention is at the other end of the age spectrum. So there's a 49-year-old lady who had a very simple VSD. Unfortunately, her VSD was operated on late. So as you can see here, she's developed pulmonary arterial hypertension, so a complication more prone in women. And at the age of 49, she starts to develop some menopausal symptoms with flushing, feeling very unwell, unable to sleep. And her questions are, well, can I have hormone replacement therapy? Are there any alternatives? Now, one of the reasons for me putting up this case is I've never, ever heard a cardiology colleague spontaneously ask a woman about menopausal symptoms. Now, I'm relatively about the same age as this lady, so I'm now a bit more tuned into this. But again, it's often a part of history taking, a part of treatment, and a part of research that so far we have completely ignored for our female patients who've got congenital heart disease. This is a slightly busy slide, but this is looking at types of contraception. This reference at the bottom is a useful one, looking at contraception for congenital heart disease patients. And essentially, if you have a high-risk cardiac lesion and a scenario where the patient really does not want to get pregnant, you need to use contraception that's highly effective. Now, for congenital heart disease patients, that might be something like an IUD. You may not want to put them through a surgical procedure. Of the forms of contraception in the middle, some will be suitable for your patient with congenital heart disease, others, like estrogens, may not. But essentially, there is almost always a contraceptive option for any patient, but you need expert advice. So you need someone who understands contraception, but also someone who understands heart disease. And some of these more poorly effective forms are definitely not appropriate if this patient does not want to get pregnant. So again, a whole area of advice that these patients need from very early in life and during that period of transition to adult care. And then just finally, there are lots and lots of unanswered questions in this field. What is the true impact of pregnancy for a long-term outcome for our patients? Does hormones impact on things like arrhythmia and heart failure? Well, we think that's probably true. We're not even going to touch, and I think Shereli will mention this, about the psychological impact of many of these issues and how that manifests in women in a different way than men. Impact of things like body image, all the other psychological issues that normal teenage and young adult women have to deal with. As I said already, menopause, again, is the black box, has not really been investigated in terms of congenital heart disease. And really how, and as I say, Valerie touched on this, how we access high quality advice for these patients. So I'm going to hand over now to Shereli, who is a nurse practitioner in previously congenital heart disease, now in cardiovascular surgery and critical care. And Shereli is going to take forward some of these issues for us.
Thank you, Lorna. I'm just trying to get access to the slides. Okay. First, I'm going to start discussing the challenges to care for people living with CHD. As we all know, as Lorna and Valerie already mentioned, this doesn't affect only the heart, but it's a multi-system disease
And our patients have many reasons physiologically to increase their surgical risk. I'm starting to talk about surgical risk as a challenge because I'm a nurse practitioner that is currently taking care of patients after surgery, congenital and non-congenital patients. Unlike acquired heart disease, our patients have several factors we need to consider before and after surgery for them to have a successful recovery. Our patients often are undergoing redo surgery. They have arrhythmias, bleeding problems, lung problems, complex congenital heart disease, often accompanied by heart failure, neurocognitive challenges such as mental illness or other cognitive challenges, liver and kidney problems. So they are quite complex, and we need to take the time to assess them in detail before and consider all these factors after surgery. Besides the surgical risk, there are other challenges our patients face. A lot of these ones were already mentioned by Valérie. The travel distance from our center. Most highly specialized CHD centers are downtown, are very centralized, and patients cannot afford living downtown. They are far away, so it's really difficult for them to make it to their appointments. They have to take time away from work and school that can disrupt their routines, their structure. They have limited medical benefits like dental care. So it's a bit ironic that we advise them to go to the dentist every 6 months when they don't even have coverage. They have young families and childcare, and this is especially important for women with CHD as they need to arrange childcare, which is quite difficult in order to go to their follow-ups. So there are different challenges that they face. The evidence shows that 90% of children born with CHD reach adulthood, but this is accompanied by long-term morbidity that in the long run affects their emotional stability. Children with CHD have more behavioral, emotional, and neuropsychological problems compared to healthy peers. Nowadays, the American Heart Association is recommending early screening and identification of these children at risk. And so the focus is to intervene early in order to avoid persistence of or worsening of all these issues through adolescence and into adulthood. Now, what we need to remember is that this strategy for early intervention is relatively new. And as Valérie mentioned, there's a lot of patients that are adults with congenital heart disease that were likely undiagnosed, misdiagnosed. So we need to support them. Now, what are the psychological considerations of patients with CHD? Children, teenagers, and adults they face different challenges. The National Heart, Lung, Blood Institute and ACHA working group has actually identified cognitive and psychiatric outcomes as a priority research topic. So there is a lot of focus on this nowadays. First, what are the psychological considerations in children? Brain injury can be present in 56% of infants with CHD. White matter injuries and perioperative ischemic strokes are the most common. This can lead to neurodevelopmental outcomes such as lower IQs and higher attentional problems. This chart here shows that the more complex your congenital heart defect, the higher risk for cognitive impairment. Also, children with CHD are at higher risk for ADHD than healthy peers. Besides all these structural abnormalities, children also face different factors that exacerbate these deficits. They can undergo, on average, 1 to 5 cardiac interventions in their lifetime. Surgery and recovery time affect traditional education, making them miss days from school, exams, maybe lose the year, so they feel they cannot keep up with peers. Surgical scars and physical deficits lead to embarrassment and isolation. All of these combined will lead to more cognitive impairment, impaired social interactions, inattention, and impaired executive functioning. Unfortunately, all these issues do not end in childhood. But what about parents of children with CHD? Research shows that they experience more psychosocial morbidity, and this is quite obvious. We understand that. But also a substantial proportion of them feel that they don't get adequate information about the children's condition, treatment, and medical prognosis. And this research study demonstrates that a factor influencing their satisfaction and well-being is for us to fully inform the parents about the children's condition and treatment and prognosis. Now, what are the psychological considerations in adolescent and young adults? They tend to have lower educational attainment due to several factors. One of them is physical limitations. Attending college or university with large campuses might be difficult for them to walk long distances, or if they have heart failure, they are short of breath, it's hard for them to do that. There is also a belief of short life expectancy. Either they heard it from the parents or patients believe themselves that it's futile to complete a degree because you are going to die younger anyways. Disruption in routine, such as finishing school, moving from parents' home, or transferring to adult care. Some of the evidence shows that lower educational attainment leads to unemployment. Interestingly, men are more unemployed and women work part-time. Teenagers with CHD often have difficulties with interpersonal relationships and engage in risky decisions. And by that, I mean not using birth control, having multiple sexual partners, or having sex under the influence from alcohol or drugs. CHD teenagers are less sexually active than non-CHD patients, but 72% of our patients engage in risky behaviors, and this is quite worrisome, especially for women. And teenagers with CHD use drugs despite of knowing that these affect their cardiovascular health. So all of these points are really important for us as HCPs to consider when we're educating our patients. What about parents of adolescents with congenital heart disease? Parental overprotection, it's a problem. Evidence shows that this is associated with higher rates of substance abuse and heart-related anxiety. So it's important that we support parents to help their children be more independent and more autonomous. And I have seen that in my practice, and I hear this from Valérie. Having supportive parents that allow you to be autonomous and independent can have very, very good outcomes. Lastly, the psychological considerations in adults involve that they report difficulty with math, memory, and attention. They have higher executive dysfunction, and they have low scores on cognitive screening, which means that they will have low educational attainment and unemployment, less romantic relationships, which means isolation, higher sexual dysfunction, anxiety, depression, and PTSD. This is showing us some of the numbers of depression and anxiety in ACHD in North America. 28 to 35% meet the diagnostic criteria of psychiatry diagnosis, and prevalence of mood disorders is triple than in the healthy population. Sadly, unfortunately, only 0 to 31% of our patients receive mental health treatment. And as a first world country, we can do so much better than this. On top of everything else that I mentioned, our patients have to face these social constructs when you have a CHD. The being different versus not being different, revealing your CHD versus not, social isolation, teasing and bullying, body image concerns, employment and insurance problems. In other words, they face a world of stress with very limited resources. So what do we do about it? The best way is to tackle this with an integrated care approach. How do patients want it? They might want individual and group therapy or mentorship or patient conferences that helps them with counseling, connecting with other peers or psychoeducation. There's all kinds of different ways to help them, to support them. How do we advise patients? It's difficult because we have very limited resources. However, the first step is to talk to the primary healthcare provider, the nurse practitioner, or the family doctor. They can be referred to a psychiatrist, which is covered by OHIP. We can provide them with knowledge about hospital, LIN, or provincial mental health programs that are free because, for the most part, people cannot afford these services. Other options, if they are working full-time, they can apply for the employee assistance programs through work. We can give them information about CHD patient organizations. There is always useful resources. and or we can refer them to the Big White Wall or Bounce Back program, which are free government programs for anxiety and depression for our patients. As I said, we don't have a lot of resources, but we have to make the best of it. So my key take-home messages for HCPs caring for women with CHD, one is that adolescents with congenital heart disease might have their periods a little later, or they are more irregular than the healthy patients, and sometimes this is worrisome for young girls. 72% of sexually active CHD patients engage in risky sexual behaviors, and this is really, really concerning for me. So as HCPs, we have to discuss with our patients in every encounter birth control options. As Lorna mentioned, there are all kinds of options for these patients, depending on the severity of the congenital heart disease or depending on their sexual practices. If they have a partner for many years, an IUD might be ideal. But if they have multiple sexual partners, we need to educate them about STDs, as they can lead to endocarditis, and this can be deadly for a patient with congenital heart disease. If you're unsure, you have to refer to a specialist, of course. Then the next point is that we need to refer the patients that want to become pregnant early enough to an ACHD pregnancy specialist, because they need pre-pregnancy evaluation and genetic counseling. And lastly, we cannot forget about the mothers of children with congenital heart disease. All the evidence shows that they have more psychosocial morbidity, and for obvious reasons. So we need to provide them with most resources that we can, and support them in their journey. Thank you for listening. Now I'm gonna pass on to Cindy. Can you hear me, Cindy?
Thank you very much with all our amazing speakers. Just to round this up, before I open up to questions, which you have many of on the channel, I just want to really highlight that there are a fair bit of resources that you can share with your patients, you can share with your family, so that they can be more familiar with the transition of congenital heart disease from pediatric to adolescent and adulthood. On our website, heartandstroke.ca, we have posted a care tip sheet, as well as we have 5 new resources you can see up here, which speak specifically about birth control and congenital heart disease. And lastly, just a quick reminder, please help us spread this word and raise awareness. The more people know about this, the more we'll be able to provide better care and engage on a social media conversation, even after this conversation here in this webinar, by following us at hashtag CHD Awareness Week, hashtag CHD Awareness, and hashtag Heart Month. With that, I'm going to open up with the first question. Valerie, I think it's to you. During the time that you are presenting, a question came up, and it was asked by Stephen in Cerebral, that in what mode is your pacemaker set? Would you be able to comment a little bit about your experience with your pacemaker, Valerie?
Well, I don't know which mode. I just know that the pacemaker was put in when I was 17 because my heart was going too low during the night. So I know that the pacemaker will turn on usually mostly at night during effort, during like when I work or when I do exercise. I don't think it's turned on. I know for me, because it's an abdominal pacemaker, the change of the boîte is not too difficult. It's not a big deal. I remember when they've put in the lead, the wires, that was something, but I didn't have to change them again. So it's for me, it's a life-changing experience, because at least I could sleep, and I could, when I was waking up, I was now, in better condition. But for me, it was never been a big thing, basically. I know it can be for a certain patient, but I'm not sure if that's the information that that gentleman wanted, but for me,
I think that's great. Yeah, I think that's great. Even just sharing, I think it's often, I think what you are alluding to, that often individual living with congenital heart disease may not actually know what the specific setting or treatment that they actually received in great details, right? But you can share that experience. Thank you, Valérie.
No problem.
The next question is to Lorna. An audience has asked, is there often a genetic concern with a Fontaine defect? Lorna, over to you to address that.
Yeah, so the Fontan is obviously a surgical treatment, but the Fontan's done for a wide variety of conditions, most of which are not highly genetic. So if I'm counselling somebody, I'll say the background risk of anyone having a baby with congenital heart disease is about 1%. A mother who's got congenital heart disease, the overall background risk is probably of our baby having a risk of about 3 to 5%. And the Fontans would be in that kind of lower risk group. So not highly genetic.
Great, thank you. And I know that our last presenter, Shereli, you have mentioned a lot and have a great perspective in terms of the psychosocial aspect of congenital heart disease individual. Can you further comment on, there's a question on here asking, what would be some of the new approach to tackle this gap? What would be the number one thing you will want this audience to take away from, in order to tackle the social psycho aspect of congenital heart disease?
What I would say is that your heart is connected to your mind. So for the most part, patients do struggle with anxiety, depression. So I think it's very important for family doctors or nurse practitioners that they discuss how the patients are doing from this perspective every time they meet. From my own experience, when I go to the doctor or the nurse practitioner, they address a specific topic that you're going for the visit. And I think that if your patient has past medical history of congenital heart disease, it's very important to discuss with them how are they feeling and if they need any resources. It's not complicated to diagnose someone with anxiety, with depression, or simply to provide them with support groups or information that can help them. But the goal is to target these issues early before it's difficult.
Great. So going back to Valerie's point at the beginning of the presentation, really to have that dialogue and have that conversation. Great, thank you. The next question I have here is the stroke risk with congenital heart disease an issue during treatment or surgery, or are there any ongoing concerns regarding congenital heart disease individual having higher stroke risk? So maybe I'll turn that to Lorna to start, and then Shereli and Valérie can share your perspective as well after.
So as a population, yes, there are increased risk of stroke, but that is very multifactorial because in the mix of congenital heart disease, there are a huge range of different lesions. So on one end of the spectrum, for something very simple like a PFO, which has a stroke risk, right up to someone who's cynosed and cyanotic, who has a stroke risk, but for a completely different reason. So in the mix of that are multiple lesions. I would say arrhythmia is one of the biggest drivers of stroke. But yeah, so as a group, there are multiple reasons why they're at higher risk of stroke.
Okay. Any other thoughts added to that? Valérie, are you concerned about your risk for stroke?
No, that was never been a big concern of me. Maybe it's because I'm not aware of the potential, but I never thought of myself being more prone if I live.
Valérie's not particularly at risk of stroke, just to reassure you.
Great. One last question is, are those miscarriages and infertility concerns associated with Fontaine specifically, or generally to congenital heart disease? Maybe Lorna, want to address that question?
Yeah, so that most of that is predominantly related to Fontan. The other population of patients who have a higher miscarriage rate are the patients who are anticoagulated. So anticoagulation is also associated. But just a kind of more general point, although we're focusing on many of the difficulties with congenital heart disease today, many patients with congenital heart disease are actually very high functioning, very few complications, and will go through pregnancy without a big risk of miscarriage or complication. Today we're focused probably on the slightly more complex end of the spectrum, but just to remind everybody that the story has a happy ending for many patients.
So just the one that Valérie have shared with us, with her beautiful slides of her travel and everything that she's doing to live 100%. Great, so thank you very much. I think we are out of time, unfortunately. Continue to send us the questions, and you can contact us at strokebestpractice.ca as well. We will be addressing them, and also post a question on our social media channel. We will also be happy to address them there as well. And with that, I want to say thank you for all the audience for taking time out of their busy schedule to join us in this webinar, as well as our 3 fantastic speakers for sharing their experience and their expertise. And lastly, I want to thank our collaborators for bringing forward this very important topic to raise awareness on congenital heart disease, namely iHeart Change, Congenital Heart Health Alliance, CHHA, Global ARC, as well as Brave Heart Support Society. So thank you all of you, along with our French counterpart, which is the Foundation of Secure in Montreal, Quebec, that is supporting us in this initiative. And happy #Heart Month, everybody.